Okay, we're going to continue on with our session on head and spine trauma and talk about the specific injuries. As we discussed before, we're looking at a few major types of injuries. So soft tissue injury, skeletal injury to the skull or to the vertebrae, actual brain injury, and spinal cord injury. We'll talk with some of that soft tissue injury when we talk about the scalp. Alright, so scalp lacerations can indicate something below that scalp injury, and it's really you're gonna look at that mechanism of injury, what caused it, and that will increase your index of suspicion as to what's lying underneath it. Often, like we mentioned before, these bleed like crazy. They can be very distracting because blood is running down over somebody's face. Often people don't bleed out based on a scalp injury. So, if you have a person who is showing signs and symptoms of hypovolemia, best to look for other causes of that hypovolemia as well, because there's a chance that it's not just related to this skull injury or this scalp injury. So, our main goal: stop the bleeding. Can apply gentle, direct pressure to stop that bleeding. Be aware, though, if you feel crepitus under your fingers, then you should stop, because there's a good chance there might be a skull fracture under there, and you don't want to put pressure on that. And we're just going to cover it with a sterile dressing and transport. Obviously, we're looking at other injuries that can go along with the scalp injury. So if it was a blunt force trauma that caused the scalp to open up, what else would we be looking at? Possible brain injury, possible skull fractures, and depending on how that blunt trauma hit the head, did it snap the neck back? Do we have to be worried about the spinal cord as well? So we can see that all of these injuries are related, and we want to keep constantly checking our patient to see if there's anything else going on there. Like we said, when we're considering that mechanism, we're looking for, is there chunks missing? Is there an object impaled in the head? And if that's the case, we're going to stabilize it and keep it there and transport. And just continue to evaluate our patient, get a good neuro assessment early, and then reassess that neuro assessment as well. We're not just looking at the cut, we're looking at what else could be going on. And as you can see in this picture here, you might see if that scalp opens up, there's a lot of tension in that area, so it might actually pull the tissue apart. You might see that adipose tissue and some different layers there. And again, it can just be very distracting. So what's our main focus? ABCs and life threats. So don't become distracted by, blood all over somebody's face. Let's see. Yeah. Also, don't go poking around. We want to make sure that we're not continuing the bleeding by opening it up. Put dressing on it, keep it there. If you need more, just put it over it. Don't peel it away, because as we know with other bleeding, you could actually pull clots off and start that bleeding all over again. Alright, 4 main different types of skull fractures that we'll talk about, and our biggest concerns are, again, kind of that mechanism of injury and what injuries it can lead to, and what it can spur. So we're looking at where the fracture is, how much force, and then what fracture resulted, and that's going to kind of lead us down the line of, could there be intracranial pressure? Could the brain have actually been physically damaged? Is there pressure on the brain? How are our nerves? And go from there. So the first one we'll talk about is our linear skull fractures. These are not displaced in any way. these are, just actual cracks in the skull. A lot of times this happens in the temporal temporal and parietal regions. The bones tend to be thinner right in those areas, so if it's going to break, it's going to happen through there. A lot of times this happens with a blunt trauma that's a little bit more widespread, and so you just get this, crack basically in the skull. There may not be any outward physical signs of this crack, besides the actual, injury that was there. You might get some slight swelling or maybe some bruising, but usually in the skull, that bruising doesn't develop right away. So you might not see it immediately. Sometimes you see those goose eggs, but those tend to be near the face more, where you have a little bit more soft tissue and a little bit more fluid to give. So you'll see those things. What we do for this, when we're assessing for these, we're palpating the whole head, right? So we're using the pads of our fingers to go over the head, and we want to be thinking as we go over this, I'm touching the frontal, the parietal, the occipital, the temporal regions. And what am I feeling for? I'm feeling for that decap BTLS, right? I'm feeling for any deformities. I'm feeling for any squishy spots that, could be a contusion. I'm looking for any outward bleeding, right? So is there a scalp laceration? Is there, abrasion in that area? Is there any crepitus in those regions? Any swelling? So we're going through and we're assessing for all of those things. When we get to a depressed skull fracture, here's where we're, even more concerned. With that linear skull fracture, there might be diffuse damage on the brain. So there might be a diffuse injury to the brain. So that person might have a concussion. So we would evaluate them for a concussion along with this linear skull fracture. We would expect to see that, or we would expect to see, some signs that the brain itself has been bruised. So they might have a headache. They might have sensitivity to light. They may be very nauseous and they might vomit. They might feel very sleepy. You might see some changes in the pupils where, they're either slow to react or they're unequal. So we're looking at the whole person here. If you come across a depressed skull fracture, this is usually very high energy, direct trauma in a smaller area. So it's not spread out as more diffusely as that, linear fracture is. Usually there's been a loss of consciousness that goes along with this. The person may or may not remember what happened. And likely there's other neurosigns that go along with it. They might be confused. If they are, alert. And so we would expect to see some other things with that. Basilar skull fractures, usually this is a more diffuse impact to the head. So you see this in MVAs where, the head is moved forward or slammed back on the seat. Not only do you get those coup counter coup injuries, but you could actually have a skull fracture that goes along with it. And I'd be worried that there's other injuries as well to the body, with this injury, because that's, thinking about where you're getting, where that is. That's, a difficult place. It's a pretty well protected place. People don't usually, just end up with damage here, from simple falls and things like that. This is more, extreme force being applied to the body. A lot of times we'll have drainage from the ears from this because of, being so close to that auditory canal. So you could have bleeding. There might be cerebral spinal fluid mixed in with that. Do I really need to know? Not really. I'll just assume that there is, because if there's bleeding, I assume that there's a break and a breach in that skull cavity. So I would just, if I saw blood coming from the ears, just assume that CSF is probably mixed in there. You can do a halo test where you put a little drop of blood on a piece of gauze, and if there's cerebral spinal fluid, it will spread out. You can also check it on a glucometer, and it will be higher than what their blood sugar reading, off of a finger prick would be. But to be honest, I would only do that if I had lots of extra time, because I would just assume that it does have CSF in it, and I would just treat them accordingly. I don't really have to identify that out in the field. The bruising that you get around the eyes and so that periorbital ecchymosis and the ecchymosis that goes behind the ear, those battle signs, those can take up to 24 hours to really, become pronounced. So don't count on seeing that. It's kind of like the tracheal deviation of a pneumo. You don't always see that, right away, or the, cherry red skin with CO poisoning. Those are all things that are late signs. So, don't just rely on those. All right. So, and don't write it off if you don't see it. Anytime I have bleeding from the ear, I'm immediately going to think basilar skull fracture. All right. Open skull fractures. Anytime that you have a piece of skull missing, basically. It's been fractured so much that it's fragmented. It's actually missing. You have blood, cerebral spinal fluid. You see parts of the brain. Pretty bad sign. All right, so this is, somebody who's sustained some pretty significant damage to open up that skull. We see this a lot with gunshot wounds. That's probably one of the biggest things that I've seen it with. I've seen it with train versus car injuries or incredibly high velocity impacts. But probably gunshot wounds being the biggest time that I've seen this. Pretty high mortality rate with these folks. Usually, once you open up the brain, there's usually so much damage there that they're not able to survive. But in the case where they can, we're going to cover it with a moist, sterile dressing. Put that over it just to protect that tissue underneath, including the brain, and then cover it with a dry, sterile dressing just to, cover that area, just to try to keep any further infection from occurring. Because if the actual force damage that caused this injury doesn't kill them, then the infection that sets in later will. So you really want to do whatever we can to protect them. And with these types of injuries, we're looking at, injuries to a lot of different areas of the body. I have a huge airway concern because they probably can't control their airway. Plus, I'm suspecting that there's more damage throughout that area. Big risk for spinal injury that goes along with these just because of that impact on the head and that movement and that jarring. If it was enough to, go through the skull like this, it was definitely enough to damage vertebrae and impact that spinal cord as well. So definitely with these, we're aware that there could be other injuries noted. And again, probably while this is an interesting thing to see, because you don't often get to see the brain from the outside, don't let it distract you. And remember that we really have to go back to looking at the ABCs. That's got to be our main focus. All right, so this is, we've already talked about this, where we're using our fingers to go around every part of the skull. We're feeling the forehead and the frontal bones there. We're going over the parietal, the occipital in the back that sticks out. We're checking the temporal region. We're working our way down. We're then just going to assess the C-spine as we go down. And in these cases, we're definitely going to want to get a C-collar on them. At a minimum, I would like to keep them with inline stabilization, especially, the open fractures or basilar skull fractures, or really even depressed skull fractures. Pretty much any skull fracture, I'm going to take C-spine precautions. There's likely loss of consciousness or a decrease in the level of consciousness, so it would warrant spinal immobilization. This can be a very big distracting injury. So again, there's probably other injuries as well. Those distractions warrant putting them in full stabilization. I would like to use a vacuum mattress. Maybe a vacuum mattress combined with a backboard would be my best option here. And of course, before I put them on that, I'm doing a very good job of checking out the back side before I roll them on there, and go from there. Alright, talking more about, specific brain injuries and how that comes about. We talk about, our closed head injuries, which are more of those linear skull fractures, those depressed skull fractures. It tends to be more closed. And then when we talk about open head injuries, that's where we have, those penetrating traumas typically that open up the skull, that expose the brain tissue, and go from there. To go along with the skull and the soft tissue injury that's out there, then we actually have brain injury. And TBI, otherwise known as traumatic brain injury, is pretty significant. So 30% of trauma deaths are related to TBI, and I think we talked about that. 25 to 30% of trauma deaths are associated with chest trauma. So between those two, we've already seen the majority of our trauma deaths are from those two types of trauma. You have many visits to the ER every year. Some of those go into hospitalization so that they can be watched for further deficits or treated with surgery to try to relieve some pressure off that brain. And we've seen an increase overall in the number of traumatic brain injury visits to the ER. From 2007 to 2013, they saw an increase of about 50% in that time, and that trend has continued, and I don't have recent stats on that, but anecdotally I know that trend has continued. Thankfully, the number of deaths associated with those actually went down, but the incidence of this trauma, and maybe just the recognition that there is brain injury that went along with the head trauma, has come around. And I think they're doing a lot more to recognize more concussions and things along those lines. So that might also contribute to the increase in numbers. So what causes head trauma? Motor vehicle crashes are a big part of it. Unintentional blunt trauma. So, whacking your head up against something, having, running into something, having a door opened into your head, or, something along those lines. Cabinet doors, you see this a lot with that. Somebody else is getting something out of the cabinet, the other person stands up quick and gets smacked with the cabinet door, or doesn't realize that somebody's opened the door and just left it open, because apparently that's what some people do. A lot of people in my family do that. And so, you just have cabinet doors open, you stand up and you crack your head on the cabinet door. So we see a lot of things like that. Unknown or other, so that would account for some assaults and other injuries that can occur. And then you see the majority of them are falls. And for whatever reason, we tend to lead with the head when we fall. So especially in your pediatric patients, they smack their head every time they fall. It's ginormous on their little bodies and bobbles around a lot. And they tend to, just fall and smack their head. We also see this with our significant with our elderly patients who have become or have had issues with being mobile. They fall more often, balance is off, they don't have the reflexes to catch themselves, and they tend to hit their head more or have more head trauma. Even if they don't think they hit their head, still that brain is sloshing around in there because it's shrunk by 7 to 10% after the age of 60, and it just has a little bit more room to move, and that can cause injuries. And we also see, with people falling off roofs or ladders or out of trees, or off of unstable chairs that they use to get something off of a top shelf, you see, head trauma occurring. Alright, so when we talk about traumatic brain injury, we split those, just like we do spinal injuries, into the primary injury, so that was the actual direct injury to the brain, and then secondary brain injury. That's usually, a consequence of that first injury. We see that, coming through where it's either the swelling that was a result of that first injury is causing even more issues. So when we talk a little bit about that secondary brain injury, we can have increases to the intracranial pressure. We can have ischemia to the cerebral tissues, and hypoxia. We can actually have hypotension that then causes more issues. Those infections that we talked about are other secondary injuries that are just a result of that primary injury occurring. All right, where do we see a good amount of our brain injuries? We have MVAs that we talked about. So when we talk about these counter-coup injuries, we have somebody who's traveling along at 50 miles an hour, hits a tree. There's that sudden deceleration, from 60 to 0. The head moves forward. As the head moves forward, then the brain, inside the head moves forward. So you could have the head impacting the steering wheel, but then what you see is that inside the skull, the brain actually moves forward and hits the front of the skull. And then as everything comes back, the person comes back, that brain sloshes back and hits the back side of the skull. So the frontal movement is the coup injury, and then that hitting of the back is that counter coup injury. And this tends to happen when either there's been that sudden deceleration, like we said, from going 60 miles an hour to a sudden stop, or if somebody is rear-ended. So you'll see, they get hit in the back, that pushes everything forward, and then also, pulls things back. This is, an issue because we have, bruising that occurs on the brain, and the result could be swelling. You could have vessels that get torn as that brain sloshes back and forth, and that increases with age as well. All right. So we could also have this with lateral impacts And instead of it being the front and back of the brain that gets bruised, the sides of the brain gets bruised if there's a lateral impact and this head moves to the side, towards the shoulder, versus, front and back. All right. Talk a lot about increased intracranial pressure, and remember we talked about this a little bit in our neuro lectures as well, where there's no space in the skull. So if you have bleeding in the skull, if you have swelling in the brain, then there's really nowhere for that to go. So instead it just keeps increasing that pressure. And what can move? Well, that spongy brain can move. So it gets compressed, we have functions that we lose, and the extent to which we lose those functions and the chance of getting those back is just dependent on the amount of damage there. Remember, we need a certain amount of cerebral perfusion pressure, so there needs to be a certain difference in pressure between the arteries and the capillaries and the brain tissue, right? We need a certain amount of pressure in order to allow that oxygen to push from the vasculature and into the brain tissue, and that's our cerebral perfusion pressure. And that's basically equal to the amount of pressure in the arteries, so that mean arterial pressure, minus the intracranial pressure. And so you have a little bit of intracranial pressure that's just there, that's just involves the amount of the tissue that's in there, the cerebral spinal fluid that goes around it, and typically that's about 5 to 15 millimeters of mercury. And usually the MAP is around 85 to 95 millimeters of mercury. And remember, the MAP is just a combination of your systolic blood pressures and diastolic blood pressure, and a little math that goes along there. There's several different ways that people calculate that pressure. So just know how they want you to calculate it in your area and go with that, learn how to do that and stick with it. And it can tell you a lot. And when we talked a little bit about shock and bleeding, there's more of a push for us to start using the mean arterial pressure as opposed to just that basing things off the systolic. But again, one of the most common ways to calculate it is just that diastolic pressure plus a third of the pulse pressure. So you can, just take a look at that. And typically that ends up being 85 to 95 millimeters of mercury. Now, so if your typical is 85, and your typical ICP is 5, then that's going to give you a cerebral perfusion pressure of 85 minus 5 or 80. And that's right there in the ballpark. Our typical CPPs are 70 to 90 millimeters of mercury. Anytime you get an increase in your intracranial pressure that takes it above 15, certainly above 20, you're going to have a decrease in that cerebral perfusion pressure, which is going to decrease the amount of oxygen that's allowed to get into that brain tissue. It will actually start to decrease the blood flow into the skull and around that brain. So what does the body do? It says, all right, I need to increase that pressure. How am I going to increase that pressure? Well, I can increase my MAP. So it's going to, how does it work? So I'm going to increase that MAP. How can I increase the MAP? How can I increase, well, it's calculated off the blood pressure, so how can I increase those blood pressures? One way is to increase the heart rate, right? So if I have more cardiac output, my pressures are going to go up. The other way is to clamp down on the vasculature and make that container smaller. So that will increase that pressure. So once I do either of those things, I increase the blood pressure. If I had a leak in the vasculature that was causing bleeding inside the skull, if I increase the pressure, what happens to that bleeding? We bleed more. So now I have more fluid in the skull, which is making even more pressure inside that skull. So I have even more of an increase in intracranial pressure. So my CPP is down again. So what does the body think? I have to increase my MAP. I have to increase my blood pressures. So it clamps down harder on that vasculature. It increases the blood pressure. That bleeding increases again. That intracranial pressure keeps increasing. And so you can see that this is just a downward spiral of for that patient, because their pressures just keep increasing. And you'll actually see this when you're trending blood pressures on your patient. You'll see their blood pressure just keep climbing. You know, maybe it starts out at 130 over 74, and then, you know, the next time you take it, it's 140 over 76, because your diastolic is going to start to rise as well because of that clamping down on the vasculature. And then it just keeps going, and you can have, you know, like 220 over 110. And you're going to start to see, you know, neurological defects from that, and they're going to have some deficits there. All right, so the lowest cerebral perfusion pressure tends to be about 60. That's our kind of our minimum, our critical number. And when you have pressures of over 160, then you have something that's called hypertensive encephalopathy. Yeah, I can't say that word. I'm not even going to try it today. So then you have, you know, increased pressure in the brain, and that's now causing you your problem as well, and you tend to get fluid shifts and things like that. All right. So what does the body do, you know, to try to figure out, you know, how to handle this intracranial pressure? Well, we know what it does as far as the blood pressure goes, but what other things can it shift? So what ends up happening? Well, you might get that leakage of cerebrospinal fluid. So they might start leaking that, especially if there's any tiny holes. It will work its way through there, and it will reduce, you know, blood flow. So that pressure on the venous side tends to limit, you know, flow coming through there, and you'll see, you know, how this is kind of a representation of that, where this is our normal level. You have about relatively this much cerebrospinal fluid, you have this much brain tissue, you have this much blood volume. Well, as that intracranial pressure continues to increase, you'll see that blood volume will go down relative. The cerebrospinal fluid goes down, and then that mass, or whatever that bleeding is, or whatever that, you know, thing that it's taking up space abnormally, starts to take over in there. All right, so we can actually, since that temporal area has some space, and it's the thinnest of the bones, and has, you know, not very much give, but a tiny little bit of give in there. You can actually see displaced going sideways, especially, I wish I had a picture of this here, I thought I did. But you'll actually see if, you know, brain is here and you have swelling on this side of the brain, it'll actually start to push and herniate everything over to the other side. It's a pretty bad sign when you have any type of herniation. So this is that herniation that way. You can actually have herniation of the brainstem through the foramen magnum as well. What are some of those things that can let you know that you have an intracranial pressure? Well, again, altered level of consciousness. That's a huge one. Watching those blood pressures and trending those is a good way. Somebody who has an extreme headache, somebody who's nauseous and vomiting, seizures may start, and then you know, it just keeps getting worse from there, right? So that that blood pressure just keeps increasing. You have bradycardia that sets in, because while the brain thinks that it needs a higher pressure, the rest of the body is thinking, hey, our pressures are too high. So that heart actually starts to slow down now. And so you can get that bradycardia. You can get Cheyne-Stokes respirations, where you get those erratic breathing. Your pupils stop responding. And, usually you see, the one side that is being affected, blown. They're unresponsive. And then you can have posturing that occurs. So either our decorticate posturing, where everything moves in towards the core, and this is just slightly better posturing than the decerebate posturing, where everything moves out and away from the core. So, decerebate posturing there's a good sign that they are having a herniation of that brainstem there. All right, so that's more of our increased intracranial pressure injuries to the brain. Then you also have more of your diffuse brain injuries, and I always think of concussion when I think of a diffuse brain injury. So it's kind of that bruising on the brain. Typically that brain is jarred. It hits the inside of the skull. People have headaches. They could have a loss of consciousness that goes along with this. Typically for under 5 minutes. They may not remember exactly what happened right before the incident, and so that's more retrograde amnesia. And then you could have anterior grade amnesia, which they don't remember what happened after. So this is your patient that you're talking to them, they're answering your questions, and then, they ask you, like, well, what happened? And you tell them what happened, and, you're continuing to talk to them, you're assessing them, and they're answering your questions, and then they ask you, what happened? And they just can't remember, really what's happened since that incident occurred. So they might be a little disoriented. They are often with concussions, you have sensitivity to light and to noise that goes along with it. And we see this, a lot in, not just those MVAs and falls that we, are a huge part of brain injury, but also sports injuries. We see a lot of concussions in sports injuries, and, they need to be evaluated. They want to get I know in sports at least, they're getting a baseline on everybody. So most athletes have to take concussion training, and then they need to get a baseline established. So they'll go through some cognitive exams to try to establish where they are, where their baseline is. And then if they're suspected of concussion or suspected of, any TBI, then they go back through those cognitive exams and see if there's been any changes, and any, so they can detect some deficits. Not only are the athletes required to conduct or go through concussion training, all coaches, parents are also required to go through concussion training, just because it's been so under-recognized in youth sports for so long, or maybe even if recognized, it was ignored. And there's so much more mounting evidence out there that multiple concussions, especially when young, lead to lifelong issues. So increased issues with Alzheimer's and Parkinson's, actual changes in personality. So they've seen a lot of aggressive behaviors that occur, so increases in domestic violence as they get older, and increases in substance abuse as they get older. So they're really starting to recognize long-term effects and impacts on not only life itself, but quality of life, and they're starting to do a little bit more with that, which is great. So obviously, you see this with, you think of concussions in sports. We think about football injuries. How many times has the quarterback been sacked? And you think of, like Steve Young in those cases. You also see it with wrestlers, especially, WWE type wrestlers. And then, but the biggest incidence of concussions actually comes from female soccer. So soccer is up there, and in particular, female soccer tends to have the most concussions. So it's a little tip for you for Jeopardy, if you're ever on and they ask those questions. All right, so how are we going to assess these patients? Well, obviously, just like we started off, and then we're going to look at those, cognition. Can they follow simple commands? Do they know what happened? Was there any loss of consciousness? Do they seem confused? Are they at all disoriented? Light sensitivity, noise sensitivity, presence of a headache, vomiting, or incredible sleepiness that overcomes them. And really here, it's recognition, and then the way that the main treatment for just a concussion is actual physical and mental rest. So not only do they need to, refrain from doing strenuous activity for a little bit, but they also need to just rest their brain. So they discourage screen time, so they don't want, people looking at the TV, computers, even reading can be an issue. So this is like a really boring, recovery, just basically resting. And it used to be that people didn't want, you didn't want somebody to sleep because you're afraid, like, oh, they're not going to wake up. But what they found through research, which is why, research and having evidence-based care is so important, because we actually find out what really works, is that sleeping is actually what's best for the patient. So you don't want to, keep waking them up, like, hey, are you okay? Just want to make sure you're going to respond. So, when if you know somebody who's had a concussion, treatment in the past was, don't let them sleep for too long, wake them up, make sure everything's okay. But really what they're saying is, no, it's better if they sleep. During sleep, that brain can actually start to heal themselves. All right, so some big changes there. All right. Before we get away from the concussions, okay, what is your role in this? So somebody gets hit, they go unresponsive for a couple minutes, but by the time you get there, they're alert and oriented. Maybe they have a little bit of dizziness, a little bit of nausea, but really they feel like they're okay. So they might want to sign off, they might not want to go in, and really, you want to explain to them that there could be more to it, right? Because to go along with the concussion, there could actually be a bleed that occurs. So they could have a hemorrhagic stroke as a result of that injury. So they really should be evaluated. And they should be evaluated to make sure that there isn't anything else going on. All right, and then you have the opportunity to, do some patient education on your transport in, and, just basically describing the benefits of, not of reduced activity. So they shouldn't be driving because their brain's been damaged there, right? So they'll have reduced reaction time. They can't pay as attention to things as well, and they're going to have an issue with actually operating a vehicle. Again, and then you can tell them, the benefits of why you don't want to do physical activity either, for those same reasons. Slow reaction time, reflexes are off. there's can be issues with hand-eye coordination and being able depth perceptions and things like that, which could lead to more damage and more issues. So you can start that education process in the squat on your way there, which might actually have to start with explaining to them why they should be in the squat on the way there. All right. To go along with that, and this is, while it's very rare, there is something called second impact syndrome, and this is kind of a concussion on top of a concussion. So if somebody goes back to activity too early, they get another concussion. The brain wasn't fully healed from the last concussion, and it has this just enhanced effect, and they go, sudden loss of consciousness, pupils dilate out, and then the body just shuts down. And you could see death occurs within 2 to 5 minutes after that actual impact. So it's just this, accelerated, rapid rapid reaction that occurs because their brain was still damaged from that first concussion, and then they get another injury on top of that. And it doesn't have to be something extreme. It can be, something much less impactful, something that's, it's a minimal force. It doesn't have to be some extreme force that causes this. It's just that it's compounded by the fact that the brain was already injured, and now it was injured again. So, this can commonly occur within 7 to 10 days of that previous concussion. Somebody who has this history should definitely be transported because their risk of deterioration is high. What are we going to do? Well, they go from that loss of consciousness to respiratory failure right through to cardiac arrest, and we're just going to, support and treat for those things. So we're going to work that arrest. Post-concussion syndrome, this can, continue on for months after a concussion, where they still have headaches, they still have that dizziness that occurs, have a hard time remembering things, their sleep is off, that they just get stressed. They can actually have, mood changes. A lot of anger issues can occur, during this time, and that's just that brain is still just trying to heal itself, and you have these things that just persist. So you can see that. The diffuse agonal injury, again, pretty high mortality rate with this. This is one of those, impacts where we have either high speed impacts or rapid acceleration, deceleration, forces that act on the body. And it has widespread damage. You have that brain moving. Remember we talked about that cruciform plate in the skull. It's rather rough. If the brain slides across that, you can actually have, tearing of nerve fibers, tearing of vasculature. The brain tissue itself can actually be stretched or damaged there. And this is because of the high impact. There's usually other issues as well. They tend to be, unresponsive. So what are we going to do? Just supportive care and get them to a trauma center, where they have people in-house that can take care of that patient. More, specific brain injuries. You have more of these focal or localized issues. You could have some bruising, and then, but to go along with this, they tend to have, a concussion that goes, not just a bruise, there's a concussion that goes with it. And then if, that bruising is severe and you get a severe leakage of fluid, then, now you have increased intracranial pressure that occurs. So, you have a bruise to this area, those capillaries are damaged and leaking, you have this hematoma that develops, and again, has nowhere to go. So it just pushes on the brain and causes all those intracranial issues that we talked about before. If they can recognize this and treat it early, then they can actually go through and drain this area, relieve that pressure, and reduce those issues. Remember, these are typical epidural bleeds, and epidural bleeds tend to be more arterial in nature. And look at this artery, this meningeal artery, just happens to run right here through that weakened area. So you get that force that's transferred through the skull to that artery. It opens up a little bit, starts bleeding, and there's where your hemorrhage occurs. Alright, so how are they going to present? Probably going to have a pretty good headache, and nausea, vomiting, possible cognitive issues, loss of consciousness, level of consciousness is decreased. You could also have, subdural hematomas tend to be more venous in nature, and are going to come on a little bit more slowly than those epidural bleeds. And then intracerebral tends to be more, inside the brain, where you get a little bit of bleeding. We talked about this as well when we talked about our hemorrhagic strokes. Right. Subarachnoid bleeding, again, is in between those meninges, and it's incredible to see how little blood in that area can make a huge difference. One of the autopsies we saw had a subarachnoid hemorrhage, and it was like teaspoon full of blood amount that was causing this stroke in this patient. That's basically what we've already talked about here. So, how are we going to manage? Well, it's based on that severity of the injury, right? If they can't control their airway, we're controlling it. If they're unresponsive, where we might even be controlling their breathing and their respirations. Also, if they're in arrest, then we're working the arrest. And if they're just concussed and still alert and oriented, then we're just providing our supportive care. What happens when we get increased intracranial pressure? We're putting pressure on that brainstem, and one of the results of that is that you can have an increase in temperature. So you see these folks, their temperatures go from normal to 104 within a relatively short amount of time, and can go upward of 107, 108 degrees. So what are we going to do if we notice this in the field? Is we're just going to start cooling them, and hopefully take them to a trauma center where they can get treatment to relieve that pressure, which should start to drop that temperature down. So if it's not enough that they have all this pressure on the brain, but now their temperatures are actually literally frying brain cells and causing permanent damage that way. So in the field, we typically aren't going to treat with any medications. Alright, so we're usually in the field. Our job is to recognize it, to supportive care, to get them to the facility where they need definitive care. So usually a trauma center. Typically we will not do any pharmacological methods in the field. Now, in the hospital setting, they may use Lasix, they may use steroids to reduce swelling and to reduce those issues. The main pharmacological treatment that we would use would be benzos, and that would be because of, again, treating the symptoms of this injury, which can be seizures. So, we might use some benzos to stop that seizure activity. Moving on to our spinal cord injuries here, and we're almost finished here, so bear with us. When we talk about our spinal cord injuries, is just, basically, if we can prevent these injuries, that's the best for our patients. But if there has been an injury there, if we can keep it from getting worse, that's incredibly important. We have some different types of injuries that we talk about with spinal injuries. Flexion injuries, that that head moves forward and it causes a flexion injury, especially to C1 and C2. So you can either have a dislocation in those areas that can cause issues. It can also have that transfer all the way down the spine. So we see that where you get that flexion movement, so that rapid deceleration or a direct blow to the back of the head causes that head to fall forward, and that pulls on that spine, and that's known as that flexion injury. It can be so bad that it can actually pull the spinous processes off of the vertebrae, and just actually, like break that, and then, you got to think about that spinal cord that's underneath being stretched, and possibly being impacted, especially by fractures. Rotational injuries are very dangerous. Remember, C1 and C2 are really the only ones that allow for rotation, and so when that head is whipped rapidly to the side, again, you can have fractures that occur in that area. That spinal cord itself is stretched, and anytime we stretch tissue beyond what it's supposed to be, we have damage there, and so you can have swelling that occurs in those areas, which puts pressure on that spinal cord, reduces blood flow to that area, and can cause nerve damage there. We talk about compression injuries. So this can happen when somebody is, when somebody falls. This is that rapid deceleration. When they hit, everything compresses, and those vertebrae can actually fracture just from that compression. You can also see if somebody's received just a direct blow to the very top of the head, and that energy just travels down the spine and compresses it. So either they're falling, they land on the feet, and that energy just transfers all the way up through the feet, the legs, and through the pelvis into the spine. Distraction injuries. This is kind of opposite of our compression forces. So we're actually, instead of pushing things together, we're actually pulling things apart. We see this, with hangings where the head or the upper portion of the neck is held stable, and the body pulls down on it. So you think about those, injuries there. And that those lateral pullings, and sometimes this is even called the hangman's fracture, but basically that those forces pulling cause fractures to C1, C2. The spinal cord itself actually becomes torn and pulled apart. So you can actually have a lot of different forces that can result in this. And usually, they all come together to just actually tear that spinal cord right through. Hyperextension, this is why we have headrests on the back of all of our seats. Alright, so where the head actually whips back and goes very far back, and you could actually have airway issues with this as well because of all of that force. You can actually damage the trachea in there, and this is a very, it's just unstable. Even if you just tilt your head back, your body isn't used to that. That's a lot of weight that falls back, and you can have that damage there. So if it goes way back, then the body itself has a really hard time fixing that. All right. Primary spinal cord injury, just like we talked before, we have primary and secondary injury. With primary spinal cord injury, this is, it occurs right during that moment of impact. So this could be something that lasts. It could be something that resolves. But this is the impact. This is the injury that happens right here and is having those effects right now. You can have contusions, which are, basically just bruising that can occur, and this can be a result of either there's being a fracture in that area, direct trauma in that area, any of those dislocating injuries that we've just talked about. You can have cord laceration, where you actually have a penetrating type injury. So either, like a bullet back that goes into the spinal cord, or you have bone fragments that make their way into that area and can actually lacerate the actual spine and the actual cord. And remember, this is an injury that has the potential to kill somebody, but it also has the potential for lifelong alterations in living and quality of life issues. So often, spinal cord injury is thought of as one of the most devastating injuries because of the resulting paralysis that can occur, because people who've sustained significant spinal cord injury, their chance of recovery to 100% is incredibly slim. All right, so they're looking at some sort of modified, where either they have a profound loss of function, profound loss of sensation that they never get back, or there's minimal improvement over time. So secondary injury is, remember, what happens after that. And this is where we can really play a huge role in preventing secondary injuries. So when we take spinal precautions, when we suspect that there could be spinal cord damage and we take those precautions, we can really reduce the amount of secondary injury that can occur. So really, paying attention. And this is where I think the we never backboard people anymore. This is where the danger of that is, because there's pressures to not backboard a patient, and you really have to stand your ground. And if you suspect that your patient has a spinal cord injury, or has that either very likely or you're certain of it, then protect that spine as much as possible. And if that means you put them on a backboard, then you put them on a backboard, fully immobilized, doing everything that you can to reduce all those risk factors of a backboard, like we said, padding the backboard. Even just taking a blanket and folding it and putting it on the backboard creates a significant amount of padding, and I was actually surprised at how much of a difference just a blanket can make. But it does. It really makes a difference. So just put that blanket down on the backboard before you put them on it, or use a vacuum mattress with that backboard, which is, you know, a great combination. But don't be afraid to protect that patient by using that backboard and helping them out. All right, so we talk about, you know, the anterior portion of the cord tends to have, you know, more of our motor functions and things along those lines. We see so you have a lot of the motor functions affected, a lot of the sensation is affected. Central cord syndrome, it's usually those hyperextensive injuries that is stretching everything out, and this can a lot of times this happens in elderly persons, and so causes more damage to the middle of the spinal cord, and that causes like increased weakness and numbness to the hands and to the arms, and you know, this can cause that issue there. You can also have more one-sided issues, and I think did I already talk about that? No. Alright, so you can also have just more one-sided issues when it happens to just more of one side of the spinal cord. And then, you know, posteriorly, these are also associated with extension injuries, and, you know, so there's just less sensation, so they lose all those fine sensations like light touch and things along those lines. When you have compressions of a whole nerve root, then you're going to, you know, especially in this location, you have some back pain that occurs, can be, you know, pretty intense back pain, can be debilitating. You might have loss of, I had a photo of this before. Unfortunately, my original lecture was lost in a devastating jump drive loss. So, but basically in this area, you get this compression of those nerve roots right in that sacral region, and so you get loss of sensation. You can actually have loss of bladder and bowel function, and that can cause issues there. Oh, we already talked about this syndrome where it's just on one side of the spinal tract, so, you know, you tend to get more one-sided issues. And then spinal shock. The good thing about spinal shock is that it appears as though they have extreme spinal damage, but it's temporary, and it does resolve. So this is just that jarring that can occur. This is the kind of like a stinger type thing where, you know, you get a stinger and your arm goes limp and you can't function, and then, you know, in just a little bit of time you regain that movement. When we talk about, you know, spinal damage, we also have to talk about neurogenic shock that can result. And remember, neurogenic shock, we talked about this a little bit in the first one, can be hidden at first because they look pink, warm, and dry. And so they don't have that typical shocky presentation of you know, pale, cool, and clammy. Now their pressures will still be low in neurogenic shock, but because the vasculature is just wide open, they get all of that blood flow to the periphery, so their skin stays nice and warm, looks even pink or flushed, and is dry because they, you know, we haven't pulled away and opened up those glands, those sweat glands, and allowed that sweating to occur. A big risk for these folks is hypothermia, because their blood is all on the periphery. They radiate off all of that heat. They're not able to conserve and not able to, keep. Just talking, a little bit more about, our general assessments. We've kind of already talked about this, but really, what are we looking for, and what are we going to do? We have to have a plan, and if indicated, we need to spinally immobilize that patient. Then, if not, if we've evaluated them and decide that they're not required to have immobilization, then you just move on with the rest of your assessments. We want to limit the amount of time on scene, and that's because with neuro injuries, just like with brain is, time is brain muscle, time is heart muscle. We want to be able to get them to definitive care as quickly as possible, and recognizing that they need to go to a trauma center. There have been some advancements with spinal care that have led to good improvement, where they've started rapid cooling of the spinal region to try to reduce swelling. We saw this with I believe it was a football player from the Giants. They actually started that cooling process with cooling collars in the squat on the way to the hospital, and his recovery was remarkable because of that. So another big thing is we have to remember to what's our focus: life threats and ABCs. So don't become distracted. Don't forget those things. And we've already talked about this. And we'll go over our actual things. This is actually a pretty good picture. I like this picture because it shows some of the your techniques for immobilizing. Sometimes I'll see somebody hold C-spine, and it's like they're just daintily just holding like right in the temporal region. But remember, you're there to stabilize things. So the way they have their fingers extended, and they truly have control of that patient. And they're applying light pressure to both sides of the head here. What's awesome is I'm standing here, alone, giving this lecture, but going through all of these hand movements that go along with it. So it's kind of entertaining for anybody walking by. So you go through and you're actually holding that head, putting pressure there, not allowing that movement. You don't allow movement front and back, so the chin does not go towards the chest or move away from the chest. And you don't allow for side movement as well. So you're really holding that stable. I even tend to lower my arms a little bit and go onto their shoulders if possible, just to even provide that much more stability, to just keep that head and neck and torso all aligned even more. All right, if they're not in a neutral position, and of course we're moving them into that neutral position, if you meet resistance, stop. All right, so again, it could be that there's a fracture there and you would actually do more damage by moving it. It could be that muscles are spasming so hard that it does not allow that movement. If there is increased pain with movement, if you meet resistance, just stop. All right, and before we move anybody, we'd want to check MSPs when possible. Obviously, if they're prone and you can't assess their airway and figure things out, then you just have to roll them quickly. But you're going to do so in a controlled and organized fashion. All right. So measurements for C collars, doesn't hurt to review that a little bit. You're going to go from that angle that under the ear there, that part of the jaw there, and down to the shoulder, and then you measure that same thing. People use their hands. Once you've done it a few times, you can kind of eye them up and see what they need. Most folks need a good amount of folks need just a little bit, so that either no neck or level 1 supports And then other folks, you know, who are a little taller, longer neck, go up from there. Alright, that pretty much brings us to the end here. When we're talking about you know, backboarding and things like that, we want to remember to pad the board, pad all the voids. That just decreases that movement there. Always strap down the torso before the head in case you have to roll them, and maintain that immobilization there. Alright. Our part 3 will actually be talk a little bit more about the face and the neck, and we'll be very brief.